Hello friends, good evening. I'm back with the part 3 of abnormal uterine bleeding. It's going to be very short. That's why I have added up one more short lecture, that is management of adenomyosis, which I spoke very briefly with respect to AUB, but today I'm going to talk about management of adenomyosis in young and infertile women. So let's not waste time, straight away get into the remaining part of the talk, that is coagulation onwards. COIN. Yesterday I spoke about PALM, treatment of polyps, leiomyomas, adenomyosis, and malignancies. AUB-C coagulopathy, as I said, this part of history is common for all AUBs, but with respect to coagulopathy, you have to ask family history of bleeding disorders, easy bruisability in herself, heavy bleeding during dental extraction or any other trauma, which will give you a clue that probably this lady has coagulopathy disorders, and contraception that she's been using, COCs or copper T, and medications, because she may be taking anticoagulants for other conditions, heart conditions, for example, or antipsychotics. Some of them can cause, uh, coagulation disorders. Then the medical disorders themselves will have the problems of coagulation. I'm going to talk about them soon. The special medical disorders that can give rise to coagulation failure can be ITP, ATP, or CTP. Liver diseases, because there can be hemostatic abnormalities in liver diseases. Kidney diseases, because platelets dysfunction is seen in uremia. Connective tissue disorders, the famous or the notorious one is SLE. Hypothyroidism, because there is some sort of an acquired von Willebrand syndrome in those who have got hypothyroidism. Cancer, either because of the anti-neoplastic therapy itself, which will cause pancytopenia, or the progression of the disease itself can give rise to coagulation problems. And finally, excess of alcohol intake. Hematologic complications of alcohol are well known. As I said, you have to ask the history of medication that the patient is on. For all you know, she may be taking such drugs which may be interfering with the coagulation. The drug class or substance, suppose she is taking straight away anticoagulants, that would interfere with clot formation, which will interfere with the secondary hemostasis. Or she may be taking antiplatelets in the form of NSAIDs. We all know that NSAIDs will cause low platelet count because they interfere with platelet function as well, which is primary hemostasis. Then glucocorticoids. The patient may be on glucocorticoid for other reason, like maybe SLE. They will interfere with vascular integrity as such. Antibiotics. Even some of the antibiotics can give rise to coagulation disorders. They cause vitamin K deficiency, especially with longer use. And some interfere with platelet function as well. And then SSRIs, they interfere with platelet function, which is responsible for primary hemostasis. So if the lady is taking these drugs, then you know why she's having heavy bleeding. You have to be careful before stopping these drugs because they may have been started by other clinicians, for example, cardiologist, or maybe internal medicine specialist, or maybe a psychiatrist. So we have to be collaborating with them before we take a decision. Alcohol, I told you alcohol has got its own complications, or it can cause through the liver disease. It may affect clot formation and may cause thrombocytopenia. It may cause thrombocytopenia due to direct marrow toxicity as well. So anything, alcohol, smoking, and illicit drugs, these are not good at all, both in terms of medical problems as well as otherwise psychological problems. Vitamin E, many people, yesterday I spoke about this, many people told me that they didn't know that vitamin E can interfere with vitamin K metabolism in some individuals. It's not in all individuals, but in some individuals. So you must ask this history also. They may be taking these vitamins as peppermint, because somebody would have told them you should take regularly B complex, vitamin E, and vitamin C. All these are water soluble anyway, and you don't have to worry about hypervitaminosis and things like that. But you must ask the history. Garlic interferes with platelet function in some individuals. Now, that's what people who read lots of from the WhatsApp University bulletins. They think that garlic is good for heart, so let us take garlic, and they eat everything that is stuffed with garlic. But it can interfere with platelet function as well as can cause heavy menstrual bleeding in some individuals. Then ginkgo biloba, I don't know what this drug is, maybe some herb. See, the common belief among the patients is that anything that has the word called natural and herb, Ayurveda, they think that it is nothing but nectar, and that is nothing but, that will save your life. Not really. Some of the herbs can be very toxic. Some of the plants can be toxic. We have heard people, instead of eating this particular bark of a tree, they ate other bark of a tree, and that was poisonous and they died. So just because somebody says it is natural, it is herbal, it is garlic plant and things like that, everything may not be good, and anything in disproportionate intake can give rise to problems. So also our allopathic drugs. How do you evaluate these patients? In adults, speculum examination, of course, for source of bleeding and local causes. Pap smear is a must for all adults. Colposcopy, cervical biopsy, depending upon the need. Bimanual examination, again, is a must. Uterine and adnexal pathology, whether it is any type of AUB. This is a repetition of the slide which I have shown yesterday again. Pregnancy test, beta HCG, because you have to note pregnancy. Endometrial sampling, you can use either PIPL, or if it is not adequate sample, you can go for a histoscopy guided biopsy, because histoscopy is the gold standard after all. In all the patients, you must do the minimum lab tests like CBC and hormonal assay. Ultrasound, of course, is a must, without which we cannot practice. It will rule out all the structural problems like polyps, adenomyosis, fibroids. Even it will exclude the pregnancy-related problems, because amenorrhea and bleeding could be an irregular cycle, or it could be a case of early abortion also. So all are intermixed in gynecology. So ultrasound is a must. Coagulation profile, especially with respect to AUB-C. What do you mean by coagulation profile? So we simply ask sometimes PGs, send coagulation profile. They don't know what to send for. So PT, APTT, gone are the days when we used to do bleeding time, clotting time. Of course, they are not totally irrelevant. You can still do that before surgery, we do that. But when you say coagulation profile, it is PT, APTT, platelet count, fibrinogen level, peripheral smear. These are very important. Additional tests based on the clinical scenario may ask for platelet disorder with PFA 100 or von Willebrand factor, especially in the very young girls, adolescents. Acquired factor 8 inhibitor in individuals with no prior bleeding history who present with prolonged APTT. These are not done routinely, but they are done in special situations and depending upon the clinical scenario. Early involvement of hematologists for those with evidence of hemostatic perturbations, both to assist with the evaluation and determination of likely causes, as well as help in obtaining and dosing hemostatic products if needed. Many of the hospitals nowadays have got specialized hematologists. There is nothing wrong in taking help of them. Primary and secondary hemostasis, all of us know about this. The sites and characters of bleeding may help distinguish between these disorders. All of you know that primary is basically platelet will come into help. Secondary is the coagulation factors, and the cascade will come into help. By noting the site and character of the bleeding, you can distinguish whether the problem is that of a primary, that is platelet disorders or platelet deficiencies or platelet problems, or whether it is secondary. How is that? Primary hemostasis, platelet function from secondary hemostasis, that is coagulation factor disorders. This is how you can differentiate. The major site of bleeding, if it is mucocutaneous, for example, mouth, nose, GI, or uterus, that is our menorrhagia, it is because of thrombocytopenia or platelet function, not so much because of clotting factors. So that's why I've highlighted this particular box. The menorrhagia or heavy menstrual bleeding, what we call nowadays, is basically due to thrombocytopenia or platelet function defects rather than the clotting factor deficiencies or inhibitors. If it is that, then it will be deep tissue, for example, joint bleeding, muscle bleeding, or soft tissue hematomas. These are due to clotting factor deficiencies. Petechiae, if the lady has got petechiae, in addition, again, it talks about the platelet function problem. In clotting factor deficiencies, petechiae is not seen commonly. Ecchymosis, again, it's a platelet disorder rather than clotting factors, but one may develop large ecchymosis if there is an additional clotting factor deficiencies. Excessive bleeding after minor cuts, again, it suggests thrombocytopenia. But all of us know when there is a cut, the first person who is going to rescue us is the platelet, not the clotting factors. They come later. Excessive bleeding with surgery or invasive procedures, of course, here both will be there. Often intermediate degrees varies with severity of the defect. Often during the procedure, some individuals may experience delayed bleeding. That is factor VIII deficiency. So basically, the heavy menstrual bleeding is due to thrombocytopenia or platelet function defects and less due to clotting factor deficiencies or inhibitors. So having understood this, let us look at the management of AUB-C, that is coagulation disorders. The general or gynecological management, so to say, NSAIDs are contraindicated in platelet function disorders. See, sometimes we give NSAIDs for the in heavy menstrual bleeding, but when we give that, we know they cause platelet deficiency, and we have just understood in the previous slide that heavy menstrual bleeding is mainly due to platelet deficiency. Suppose the lady is already having platelet deficiency, you are adding fuel to the fire. So NSAIDs are contraindicated. I have written in red color. Remember this. Other DUBs or other AUBs, NSAIDs are very, very useful. Antifibrinolytic agents such as epsilon aminocaproic acid, EACA, or tranexamic acid can be given. COCs, especially useful in von Willebrand factor, and they will normalize the hemostasis. So COCs can be used in young girls. LNGIS acts locally and suppresses the endometrium. So that is actually LNGIS has revolutionized the treatment. So many so-called non-surgical options that we had, what do you call, the thermal balloons and the curettage with the electric medias or any other gadgets, all that have gone to the side after the advent of LNG-IUS. So that is very good, whether the problem of AUB is either due to endometrial or ovulatory or adenomyosis or fibroid or coagulation. Every slide you will see LNG-IUS. That is wonderful. Platelet transfusion, of course, you may consider to raise the platelet count to at least 50,000. 50,000 is the minimum. All of us know that even from obstetric experience that if you want to take a person for cesarean section or in a case of severe preeclampsia or HELLP syndrome, minimum we want is 50,000. Here also same thing. If there is concern that impaired platelet function is contributing to the bleeding, use of antiplatelet medications is going to be useful. And you have to make out whether there is abnormal platelet morphology, whether the person is having uremia because there will be platelet malfunction there. You have to rule out diabetes and heparin-induced thrombocytopenia. So these things have to be ruled out if you feel that in spite of giving platelets, there is impaired platelet function. So you have to correct these things. Otherwise, whatever you give will go down the drain. Fibrinogen or vitamin K. Individuals with active bleeding and prolonged clotting times, PT-APTT, prolonged PT-APTT, may have vitamin K deficiency, low fibrinogen levels, and deficiency of factor 2, that is prothrombin, and factor 10 or 5. So maintain the fibrinogen level above 100 milligram per dl. Clotting factor products, which are they? You can give either thrombin complex concentrate, PCC, recombinant activated factor 7, which is very expensive, generally reserved for specific indications such as reversal of warfarin anticoagulation, treatment of hemophilia with an inhibitor with either product. However, a potentially fatal situation, these products may be administered. I remember at least 2 cases, not gynecological cases, but obstetric cases, where recombinant factor, we had to get it from outside. It was available, I think, in Vellore or somewhere, and then the patient was saved. So in life-saving conditions, recombinant factor activated 7 can be used, but I have hardly heard anybody use this for AUB. Having understood clearly the AUB-C, which is mainly due to platelet dysfunction rather than so much of coagulation factor problems, let's now turn to AUB-O, which is ovulatory dysfunction. In the past, this is the one which was basically called DUB, ovulatory or anovulatory type of DUB. Anovulatory type of DUB, the reason is very clear, but why ovulatory type of DUB should have menstrual problems? And this was my favorite topic. And there was a special book called Dewhurst Gynecology, which explained beautifully the DUB. And I used to read that, and I used to, sort of show off with my fellow PGs what are the 5 different mechanisms by which the menstruation stops. It is not just progesterone and estrogen that have a big role in the menstrual cycle. There are so many paracrines or local endocrines, what we call, they have a role. Basically, there has to be a good balance between estrogen and progesterone, number 1. Number 2, there has to be a balance between prostacyclin and thromboxane ratio. There should be a good balance between PGE2 and PGF alpha. There should be a hormone called relaxin. And finally, there should be contractions of the uterus. So shall I repeat these 5 mechanisms of stoppage, which are locally acting? These are very important in a ovulatory type of AUB, which used to be called DUB. I will repeat myself. There has to be a good balance between estrogen and progesterone, because progesterone is the one which will act at the level of mitochondria, and that will help in the proper balance between different prostaglandins. What are the different prostaglandins? PGE and PGF2 alpha. All of us know PGF2 alpha is a good uterine contractor, and E is that will increase the dilatation. Number 3 is prostacyclin thromboxane. You have just now heard platelets are very important, so thromboxane is very important. If there is an altered ratio in favor of prostacyclin, there will be heavy bleeding. Number 4 is relaxin. You will not see this in any of the chapters. This is only available in Dewhurst. That's why I'm telling you. Relaxin is the one which will make the endometrium regrow. That is the beauty. There are 3 layers of endometrium, if you recall the basic science. That is the compactum, spongiosum, and basalis. During menstruation, only the compactum and the spongiosum will be shed. The basalis endometrium is retained. That is the one which regenerates, and when it starts regenerating, the bleeding automatically stops. And which is the hormone responsible for that? The 4th one, which I told you, relaxin. And finally, the uterine contraction itself is going to help in stopping of the bleeding. That's why the ladies who have got fibroids, there are again 5 to 7 mechanisms why a fibroid will give rise to increased bleeding. One of them is it will come in the way of contraction of the uterus. So that is why I'm explaining this before revealing the other lines of this slide, because The treatment of ovulatory dysfunction, in addition to the hormonal manipulation, you need to give what is called in the acute phase tranexamic acid. This is the one which is going to stop the bleeding first, because any hormone that you give will take at least 24 to 48 hours to start acting. When the lady is pouring, and if you give injection, even injection progesterone, it is not going to act immediately. What is going to act immediately is tranexamic acid. So in the acute phase, you must give tranexamic acid. And this tranexamic acid is another boon that we have got. This tranexamic acid can be used from obstetrics to gynecology, in obstetrics from first trimester to second trimester to third trimester to any type of bleeding, even postpartum hemorrhage. In gynecology, it can be given for any type of bleeding, from cancerous bleeding, menstrual bleeding, any bleeding. So tranexamic acid is the first choice in acute phase. And that is the one which is going to balance out everything. Norethistone, of course, comes the next. That is the progesterone. Yesterday, I was telling about in the acute phase, the strongest progesterone should be used, and that is norethistone acetate. 5 milligrams 3 times a day, and then BD 14 days. So 3 weeks, it is called medical curettage. For maintenance, thereafter, in the next subsequent cycles, you can give MPA 5 milligrams or 10 milligrams, day 5 to 25, 3 to 6 cycles, depending upon the HP. I told you yesterday, three cycles is for the simple hyperplasia, 6 cycles is for complex hyperplasia. This can be 5 milligrams, or yesterday I was showing 10 milligrams. Both are okay. Then ormeloxifene, 30 milligrams twice a week into 3 months. Many people believe in this. Somehow I don't believe in this. But I have inserted this because many doctors told me that they have got fantastic result with this. So I'm inserting this. COCs are other option that you can give cyclical, but the only problem is that lady has to take it properly. If she doesn't take it properly, then there will be a problem. LNGIS is the best. I told you, LNGIS you will see in every single slide. Palm coin, LNGIS will help. E for endometrial problem, tranexamic acid again, 500 milligrams TID. I didn't tell you the dosage in the previous slide. It can be injection, 1000 milligrams. Also, you can give stat, then go for 100 mg TID. Medroxyprogesterone acetate, again, it's the same thing for endometrial problems. Also, you can give, as in case of ovulatory DOB, 5 or 10 milligrams. COCs and LNGIS. LNGIS is there in every slide. Iatrogenic. Of course, you have to consider stopping the drugs, but before that, as I told you many times, consult the doctor who started this. Remove the copper T and probably you reinsert LNGIS, which will have double acting. That is, one, it will help the AUB. Second, it will help as a contraceptive device also. In fact, it came as a contraceptive device. Then we understood that it can also help in AUB. So copper T can sometimes cause heavy menstrual bleeding. Finally, AUB-N, that is not otherwise diagnosed. When it is not otherwise diagnosed, it could be the AV malformation that is only treated with uterine artery embolization. Infections, of course, we know OP and IP regimens have to be given. It's a separate chapter by itself. I'm not going to talk about that. And isthmocele, again, LNGIUS is going to help us in this. There is no need to do any surgery for that isthmocele. So I have done with AUB part 1, part 2, part 3. I have still a lot of time. So that's exactly why I have roped in a smaller topic, which I hope to finish in another 10 to 15 minutes. But before that, I'm going to give you a surprise. What is a surprise? This Friday, there is going to be a surprise speaker and a surprise package. Who is that? Guest lecture by Dr. Meghna A. Nayak. She's a specialty fertility doctor at PPAS Fertility London, UK. She's a course director for MRCOG Part 3 courses of study MRCOG. She's going to talk on pathways to parenthood. She has made very attractive slides where she talks about from A to Z, 26 conditions and their solutions. Who is she? She is my guru. She is my teacher, my daughter, Meghna A. Please don't forget to log in. Note the time. It's 1 hour earlier at 6:30 p.m. to suit her UK time, as well as on Friday, there is an international program of KCOG starting at 7:30. Usually I cancel my classes, but Meghna is free on Friday, so she can take class at 6:30 p.m. Don't miss this. So the short topic that I plan to now take in another 15 minutes is management of adenomyosis in a young infertile woman. Yesterday, I was talking about management of adenomyosis for AUB, but today we have to consider infertility. Earlier, we thought adenomyosis will occur only in multiparous older ladies, but we know that it can occur in younger ladies and it can give rise to infertility rather than multiparity. So basic principle of treatment is if it is a functional disorder, medicine will act, but if it's a structural disorder, surgery is a must. So adenomyosis is a structural disorder, so most probably it requires surgery. Unlike other structural disorder like fibroid, which can be treated by medical management, GnRH analogs, or you can use even mifepristone or uripristol, but somehow the adenomyosis will not respond that well to the medical management. Why there should be fertility issue in adenomyosis? Adenomyosis is found in a significant number of women with infertility, has a negative impact on the outcome of IVF also. Otherwise, IVF is fantastic for endometriosis, but not so fantastic for adenomyosis. Why infertility? Alterations in myometrium and junctional zone, which is very, very important. Structural and functional defects in utopic endometrium. So the endometrium, there will be a problem if there is underlying adenomyosis. So implantation will be hampered. Dysregulation of myometrial architecture and function. The moment, even if it is implanted, so uterus may undergo some contractions and it may throw out the implanted embryo. Altered endometrial function and receptivity. That's what I just now told you. The adenomyosis and the endometrium sitting on that is not going to accept the ovum. And unfortunately, adenomyosis is more common on the posterior wall, and the commonest site of implantation is also posterior wall of the uterus. Ectopic endometrial glands can trigger an inflammatory type of reaction. So that is the one which is actually preventing implantation. When we put a copper T, there is a inflammatory reaction, aseptic. Implantation failure, finally. So increased nitric oxide synthetase activity throughout the cycle is another reason why adenomyosis will cause infertility. Toxic effect of nitric oxide on sperms as well as embryo is responsible for that. It affects both fertilization as well as implantation. That's why it is tough. So medical management, there is no proven medical treatment in general for infertility in particular. Surgery is the definitive treatment for pain and abnormal uterine bleeding, so also infertility. Yesterday I was telling you, nothing is going to work except hysterectomy, but unfortunately you cannot do hysterectomy in a young lady. So here, what surgery can be offered? Why medicines don't work before that? Adenomyosis is derived from an aberrant gland of the basal layer. So basal layer is not to be destroyed at all. That is the nature's mechanism. Basal layer has to be protected for regeneration of the endometrium. It's not responsive to hormone that much. It's only the compactum and spongiosum which are grown because of estrogen and they are shed when you withdraw estrogen. The basal layer somehow will survive. How about UAE and MRG FUS? Again, the problem is most studies have addressed pain and abnormal bleeding, but results don't claim more than 50% clearance or resolution of the adenomyotic tissue. Leaving behind up to 50% does not improve pathophysiology behind infertility. We saw the so many mechanisms. So unless you get rid of it 100%, it may not help much. The shortcomings of UAE and MRGFS are poor results in massive and diffuse adenomyosis. Residual necrotic lesions may not negate the negative impact on fertility and may cause poor placentation in pregnancy. So MRGFS can actually be counterproductive. Size of adenomyoma was increased 3 to 4 months after HIFU in some studies. The reasons were related to initial size of the tumor, of course, and operation procedure, blood supply to the targeted tissues. So surgical treatment is the best. Surgery can remove near 100%. Again, it is near 100%, not 100% of the adenomatic tissue. It's not like fibroid, which has got a nice pseudocapsule and you can remove everything. Here, it is not like that. It has got tentacles. You can try to remove maybe 90, 99%. Associated conditions like fibroid and endometriosis can also be tackled by surgery. That's the advantage. MRGFS is contraindicated if there is endometriosis and adhesions, especially the bowels can be damaged by that. A therapeutic option in women with massive and diffuse uterine adenomyosis is surgical treatment. Adenomyomectomy enhances subsequent fertility as well. And Osada technique is the most popular one. There is radical excision leaving 1 centimeter above the endometrium and below the serosal surface. Midline incision is usually put from the fundal serosa to the endometrium. You insert a finger in the cavity and dissect the adenomyosis, and then there is triple flap reconstruction of the uterus. The picture is somewhat like that. You first give a tourniquet to minimize the bleeding. And then, as I said, you make an incision at the fundus, put your finger inside and try to remove as much as adenomyosis as possible. And then you start suturing in such a way that one layer and then the second layer, and then you cover that with the third layer, triple flap operation. So they claim that out of 104 cases in more than 80% of the wall, 6 centimeters, the mean operating time was 182 plus or minus 62 minutes. Mean blood loss was 372 only. Mean weight of excised tissue was 292 grams. No serious perioperative complications. All had significant improvement in symptoms, and 4 cases, that is 3.8%, had recurrence of symptoms. That's very less. 16 out of 26 conceived. That's fantastic, 61%. 12 conceived after IVF and 4 all were spontaneous. 14 had elective cesarean sections, obviously, because when you incise the fundus, that is the weakest part of the uterus, I told you in another class, you have to do cesarean section only. 2 had miscarriages, unfortunately, at 16 and 5 weeks. Xenomectomy. Yesterday, I made a mention of Zainul Rasid, my good friend, professor head OBG at National University, Malaysia. He called it xenomectomy. 28 patients, 12 conceived, 9 had successful pregnancies, no IUGR, placenta creta, or rupture uterus. Complications can be bleeding, infection. Gynecologists are well versed with tackling these complications, so nothing to worry much. Obstetric complications are there: preterm labor, IUGR, uterine rupture, adherent placenta, but conception is the main issue. We can tackle any one of them and all of them. We can tackle the complications. So where is the truth then? Whether medical treatment or surgical treatment, obviously truth is somewhere in between. So optimum treatment, GnRH analogs may be given, UAE, MRGFS can be tried, but surgery is the best. So limiting factor is, of course, the cost. So surgical plus medical, 44 women, surgery alone, 27 women, no significant difference either in clinical pregnancy rates, 79 versus 74. Successful delivery was 72% according to this study. So although combination of surgery and GnRH might provide some benefits, 2/3 of all patients still fail to become pregnant. That's the tragedy. Sum and substance, hormonal treatment has poor response. UAE, MRGFS have got limited response. Surgery is better results. Can all that be converted into goal? A lot more understanding is needed. Only 60 maximum % of patients conceived. Perhaps surrogacy is a better choice in such patients, but then you have to take a decision along with the patient's concern and consent. Thank you very much for your patient listening. Tomorrow I'll come up with a new class, new topic, maybe endometriosis. I'll continue with that. because I've finished PCOS, I've finished with the AUB, now endometriosis, adenomyosis. I have started with adenomyosis, I'll go on to endometriosis tomorrow day after. And Friday, Meghna is going to take class on pathways to parenthood. Don't miss it. Thank you very much.